Very happy to have both Dr. Mikhail and Dr. Chhabra here. I will introduce Dr. Mikhail first. He will be the first speaker. Dr. Mikhail is a board-certified metabolic and bariatric surgeon and is also certified in obesity medicine. He is fellowship trained in bariatric surgery from the Cleveland Clinic. He practices in lockstep with our bariatrician at Advocate Bariatric Medicine in the Downers Grove office and here in Oak Lawn, correct?
Yes.
The clinic is multidisciplinary, so they work with many different factors and has registered dietitians and exercise physiologists to assist patients with short and long-term weight goals. He went to medical school, all in Chicago.
All in Chicago.
All in Chicago, love it. Are you a Chicago lover?
I am a Chicago
Right,
lover, yeah. It's amazing. Best city.
Midwest. I've got kids here, there, and everywhere, but I love coming home to the Midwest. His fellowship was in Cleveland Clinic, though, in Ohio. So
Yeah.
still the Midwest.
Mhm.
And like I said, his offices are in Downers Grove and here at Christ Medical Center in Oak Lawn. And then I will wait to introduce you later. No problem. Sound good?
Okay, that sounds great. So, yeah, well, hello, everybody. I'm Alan, Dr. Mikhail. I'm just going to give you kind of like kind of a precursor of kind of things that how this is relevant to kidney disease, the treatment of obesity. It's relevant to a lot of chronic diseases. To be honest with you, so many diseases are kind of centered around if you have obesity, you can get these other chronic diseases. So we're going to talk about kind of current treatments for obesity and how effective they are, how they work. Susan kind of mentioned our program. Our program is very multidisciplinary. Although I'm like a surgeon and I do bariatric surgeries, we do a lot of obesity medicine. This lifestyle changes matter more than any intervention that we talk about here. If you don't change the way you eat or exercise, or if the patient doesn't change the way they eat or exercise, it's not going to be as effective. So we will go through it. I swear to you, I was working about like 10 seconds ago. Let me see if I can do this. We're going to do that. So when we talk about weight loss and kidney disease, I don't want to steal, this is like just a very cursory discussion about it, but why does weight loss matter in terms of chronic kidney disease? When we have extra weight, we have extra pressure, and that pressure, our kidneys are kind of like a filter, if you will. And any greater amount of pressure that we put on those kidneys can damage the filter. We're pushing things through that shouldn't go through, and that makes the filter worse and worse. And then we end up with things like protein in our urine. So any amount of weight that we can take off of us, primarily fat mass. When we talk about weight, we're talking primarily in regards to fat mass. That will improve kidney function. It also improves insulin sensitivity. So a lot of folks have type 2 diabetes. One step before that is what we call insulin resistance, where we have too much insulin in our body because our insulin doesn't work very well. If we have extra fat mass on top of us, that mechanism where for insulin resistance is only intensified more. So we have more insulin. When we have more insulin, we tend to store more fat. It's a really terrible cycle, but that also causes inflammation, and inflammation is another detriment to the kidney. So we say, like many things, if you can treat obesity, get the weight down, get the fat mass down, get the inflammation down, decrease the pressure, then you'll have happier kidneys. We'll hear more about that a little bit later. When we talk about treatment options for obesity, there's currently GLP-1 medications. So if you raise your hand if you know what a GLP-1 medication is. Yeah, perfect. So they're very, very common now. They are expensive, but they work very effectively in terms of helping patients lose weight. It's probably one of the better innovations in medicine currently. And then we have the endoscopic sleeve gastroplasty. Now we're talking about actual surgeries, the laparoscopic sleeve gastrectomy, the laparoscopic gastric bypass, a procedure called the SADE, and then a procedure called the duodenal switch. So when we talk about obesity, it's not a choice. This is a disease. So it's treated just like any other disease. When we talk about uh, a disease like heart disease, it has a mechanism of action and it's very complex. So when we talk about obesity, there's hormones that regulate how hungry we are, how we store proteins, carbohydrates, and fat. And there's also pathways that are stimulated like dopamine that are related to like ultra processed foods. And then our metabolism in terms of how many calories we take in and how many calories we burn related to our muscle mass. And then there's genetic factors to it. So if it was a choice, there wouldn't be genetic factors to it. But we only know a few of these. We know about the FTO gene, leptin deficiency, and the MC4R pathway. And then, of course, there's environmental or like lifestyle choices, right? So if we have too much stress in our life, it's not really a choice, right? But how we react to it could be. We have how we sleep in terms of raising our cortisol. Raising our cortisol increases our insulin. We have food availability, food choices that we have locally. Oftentimes, there's not healthy choices or fresh vegetables nearby, and so it's just a matter of convenience and socioeconomics. And then also sedentary lifestyle. So again, is sedentary lifestyle a lifestyle choice? I don't know, but you can see that obesity is difficult to treat because it's not one single hormone. It's not one choice. It's not one aspect of anything. This revolves around so many different pathways and so many different kind of, like we said, lifestyle choices. So when we talk about medical and surgical options for obesity, on the bottom of it, I hope you guys can see it, is like based on percentages. So these are percentages of weight loss that are from the patient's heaviest weight that they've ever weighed. So when we talk about these GLP-1s, so these medications here, so this is the most effective one. This is the Mounjaro and the Zepbound. This contributes about 20% of total body weight loss. So if you think about a patient who's, let's say, 400 pounds, okay? If they lost 20% of their total body weight, that's 80 pounds. So they're still 320, but are they healthier? Are their kidneys better at 320 than they are for? Of course. But at the same time, it's probably not enough, right? So they probably, when we talk about treating obesity, sometimes it takes medicines and surgery or surgery and medicines. So don't think of it as like, oh, I know so-and-so and they had the medications and they only lost, 20 pounds. It's really dependent on what their total, their heaviest weight was and kind of the weight that they lost from that. What else was I going to say? So these are some of the older ones. So this is Ozempic and Wegovy. And these are some of the older medications that we still use, only had access to, and we still use them. And sometimes we'll do like 2 medications to help patients lose a little bit more weight. That research is still kind of ongoing, where it's like, well, how much will you weigh if you have the gastric bypass, lost 34% of your weight, and then you add on Wegovy or something like that? How much weight would those patients lose? And that they're still trying to figure out now. So those studies are kind of ongoing. But these are studies based on, long-term data. We have like 35-year data on the gastric bypass. We have like 5-year data, 7-year data on the medication. And then the ESG is kind of like in the middle. That ESG is an endoscopic procedure that I'll talk to you a little bit more about because it's kind of like a hybrid of the two. So when we talk about GLP-1 medications, these are the medications. Some of them are used for the treatment of diabetes. Some of them are used for the treatment of obesity. But the idea here is that it's a hormone. And I always kind of just, in layman's terms, it's basically a hormone that helps with insulin resistance. So it's going to make your insulin work better. So you don't need, it's more effective in controlling your sugar. But it's another hormone that's made primarily in your pancreas. So it reduces hunger. It does slow gastric emptying, so you stay fuller longer on less food. And so that way it increases your level of fullness. Side effects with this medication, some folks don't tolerate it. And it's usually related to, this is a biased opinion, but I would say that it's sometimes not making the best food decisions, right? So if they're very high sugar or very high carbohydrates, patients don't do very well with these types of medications. They'll get increased diarrhea, or nausea. Some folks get constipation, some folks get reflux. There is a part of the study where patients lose an excess amount of weight, but their weight is disproportionately muscle more than fat. And so they're still kind of looking into this one right now, but we do tell patients it's very important to take in protein, very important to do muscle strengthening exercises, so that when you're on these medications, you're not losing muscle mass. Not eating because you're not hungry is not how these medications work. These medications are a lot more complex than that. And so folks that do that, the fear is that they will lose a disproportionate amount of muscle mass. So that's why it's very important to have dietitians and follow up with these medications. It's not just a matter of the medication. And then weight does return once you're off these medications, right? So this is just like any other chronic disease. You go on a medication. If I took your cholesterol medicine away, more likely your cholesterol will go back up. These are the same facts with these medications. Although they're used for the treatment of diabetes or obesity, if we know from the studies that when we took them away, those patients gained the weight right back. So it is meant to be a long-term, medication for the treatment of the disease of obesity, right? So that's kind of what it is. You have to kind of, again, change that paradigm or that idea of how we view obesity. We have, in terms of diabetes research, it probably goes a little bit longer, but in terms of obesity research, is about 4-year data right now that's, and it continues to be ongoing, but it is very promising. So endoscopic sleeve gastroplasty, this is kind of a newer procedure. And when I say new in the world of bariatrics or interventions, is about 5 years. And the total body weight loss for this one that we had talked about was about 20%. The way that this works is it's a camera that goes down the patient's mouth, and it's trying to kind of decrease the size of the stomach by suturing it from the inside of the stomach. So you're kind of like folding the stomach or plicating it, the stomach, to make it less, so there's less volume. It also does reduce a hormone called ghrelin, which is an appetite kind of driver. It's a weight gaining hormone. And so the patients have a little bit more control of what they're eating, and they have some restriction in the amount of food that they can eat at one time. The issue with this one is it does require anesthesia, but the patients do go home the same day. There's no incisions or anything like that. The durability of this is kind of still being figured out. So we have 5-year data. We know that those stitches can get undone. And the idea is like, well, then you just go in endoscopically and just put another stitch in to kind of give that patient restriction. It's still not surgery. So there's a little bit of fussing around with it. If the patients are okay with that, or if they recognize that, that's fine. And the weight loss is about 20%. They're already starting to kind of layer like, oh, okay, well, we'll do the ESG with medications, again, to kind of get very close to what we can get with some of the surgical options. So when we talk about the surgical options, these are all done minimally invasive. In our practice, they're done primarily with the robot. The robot does not operate for us. It does kind of assist us. And so we can control the camera, we can control the assistant. The assistant is essentially, we're assisting ourselves. So it's a very nice feature, but they're done with small incisions. And all the surgeries are going to be 1-night hospital stay as well. So just basic anatomy 101. So you eat food, it goes down into your esophagus here. Then the food transitions into the stomach. The stomach's only responsibility is to break down food. So it produces a lot of acid primarily here. The food then travels down your intestines. So you have 3 parts to your small intestines. You make a lot of juices to absorb all the nutrition. So your liver makes a juice called bile that helps absorb the fat. And then you have your pancreas, which secretes juices that help absorb carbohydrates and the protein. So the longer your intestines, the more you have kind of food mingling with the juices, and you absorb carbohydrates, protein, fat, as well as like every vitamin you've ever heard of. Then the food then goes into your colon, where absorption of water takes place, and then out. All right, so gastric sleeve. This is a procedure very similar that ESG is trying to kind of replicate this without surgery. But what we're doing here is we're removing about 2/3 of the stomach, this part here. So we get something that looks like that. That ghrelin hormone is made primarily here. So when we remove that, Again, patients feel like they're in control of food. It's even when patients, that kind of decrease of that ghrelin hormone lasts about a year or so. But if you talk to patients, even when they're a little bit further out, even though they have more hunger, they will always say, like, there's still a level of restriction that's going on. They still can't eat large portions of food. It presents kind of very durable weight loss in that perspective. It does require general anesthesia. It's done in the operating room instead of the endoscopy suite, where the ESG is performed. Side effects, long-term issues with this one is like heartburn and reflux. And then we got 15-year data on this one. So we know where patients are 80, we know where primarily patients are 15 years out. The majority of the weight loss happens in the first year. And then 15 years out, we know that the majority of the patients, or 85% of them, are approximately 30% down from their heaviest weight. That's pretty good. Gastric bypass. So gastric bypass is a procedure that kind of works in 3 ways. So I'll try to explain this in the best way that I can. But the way that this guy works is we're just kind of reducing the size of the stomach. Can you guys see over here? When I'm over here, you can see. Okay, all right. So we're reducing the size of the stomach, so you have a small stomach pouch. This rest of the stomach kind of stays in place. You're still making acid, okay? So this thing's not just flopping around, still staying there, but you still make acid. And the acid and the bile and the pancreatic juices, they all go this way. So there's juices here, and there's food going here, okay? So, but there's not very much absorption taking place because there's no bile, there's no pancreatic juice on this limb. And this has juices, but there's no food. And so from here on down is where absorption starts taking place. So I tell folks, everybody's different, but we have around 22 feet of small intestine. And this limb is around 5 feet, okay? And that limb is about like a little over a foot. And so essentially you have still about 16 feet of absorption still taking place. So you'll still be able to absorb carbohydrates, protein, and fat, should not change bowel habits, but it is a malabsorptive procedure. So you could be deficient in iron because iron, so when you eat spinach and things like that, it is absorbed here. And because since we're bypassing it, patients can be iron deficient. So the procedure, I said, worked in 3 ways. So 1, you have that small little stomach pouch. 2, that malabsorptive component to it that we talked about. And 3 is because food doesn't go past here, you increase a hormone called GLP-1, right? So GLP-1 is Mounjaro, Ozempic, all that stuff. And even 35 years out, patients, actually we're 40 years now, 40 years out, patients are still upregulating that GLP-1 hormone. So that's where this concept came from, is that, well, if we know that in bypass surgery, GLP-1 is being made, we should be using these GLP-1 synthetic hormones for weight loss as well. So very good in terms of diabetes resolution for folks. So if patients have had diabetes for less than 10 years, 89 to 98% chance of resolution. Very good for patients with terrible, horrible reflux, right? Because there's acid here and it doesn't touch their esophagus. So it splashes back, but it's never going to touch their esophagus. So it's very good for those types of patients. But it's not without issues, right? So the vitamin deficiency we talked about, also this connection here between their stomach and their intestine. They're at higher risk for ulcers. So if they smoke, do like nicotine, if they drink alcohol, if they take these medications called NSAIDs, ibuprofen, Motrin, naproxen, Advil, Aleve. A lot of the kidney patients that we see, we don't really love doing this procedure on them because it's malabsorptive. Depending on how severe their kidney function is gone, if they need a transplant, it is a malabsorptive procedure as well. So, but we have pretty durable data on it as well. All right, so this is the last kind of surgery that we're going to talk about, and then I'll spare you all the anatomy, and then all right, so this is kind of, again, newer. It's been around for we have 10-year data on this. This is basically like a sleeve with a super long bypass, okay? So this is reserved for a very special patient. These patients have BMIs that are much higher. So these are patients maybe with BMIs of 50, 60, maybe they had a sleeve, maybe it's like that 400-pound patient that we talked about, right? So they had, their weight was 400, they've got down to 320, and they've had a sleeve, and it's kind of like, okay, where do we go from here? So this one contributes to kind of the most amount of weight loss. It's almost 40% total body weight loss. And basically what it is the sleeve, and then just beyond the stomach, just with the end of the stomach is called the pylorus, that first part of the intestine, we divide. And so what happens here is that you have juices, right? So you have your pancreas here and your bile, and all the juices are going through, but there's no absorption happening in about 2/3 of your intestines. So finally, food and juices mix, and from here on down is where absorption takes place. So it's a short run. It's about 9 feet. So it's like, like a third of your intestines. So this one definitely has, changes in bowel habits. So we usually tell folks that they might have to double their bowel movements, the number that they're having. It also affects fat-soluble vitamins. So we talked about iron in the gastric bypass. But fat-soluble vitamins are vitamins A, D, E, K. So vitamins A is for your eyes, right? Vitamin D, everybody in Chicago is deficient because we live too far from the equator. Vitamin E is like for cell walls. And then vitamin K is for coagulation, so just, stopping bleeding. And so these are big deals. If you are deficient in vitamin K or vitamin A, even vitamin E, but vitamin K or vitamin A, it can become a very big deal. So very important these patients are following up. Very important these patients are getting vitamin labs, including vitamins A, D, E, and K, which most docs do not check on patients that unless they have a procedure like this. So we kind of know, right? So it's going to work in 3 ways, but it's a little bit magnified, right? So we have the sleeves, you're going to have restriction. 2, the malabsorptive, but it's like definitely higher than what we would have with the bypass. And again, because food is not going past your pancreas, you have that GLP-1 hormone. So these are for patients that, they don't have to take a GLP-1 hormone anymore, but there is a cost to it in terms of lifestyle change. There's a cost to it in terms of making sure that their vitamins are where they're supposed to be. But it's a pretty powerful metabolic treatment for, again, a pretty serious patient who's got a lot of metabolic disease. So I will I'll come back up if you guys have questions, all at the end. So that way, we can both kind of handle both of the questions together, because some of them I'm sure will be related to the kidney disease and some of them are related here. But our office is in the outpatient pavilion at Christ, and we offer all services: dietitian, exercise physiologist, and myself. So how do I go to the next presentation? Okay, that's fine. Yeah. Yeah. No, that's okay.
Hi. Thanks, Dr. Mikhail.
Oh,
for
my pleasure, my
the
pleasure.
awesome information you gave about obesity and the many medical procedures that can be done to avoid obesity. Our next doctor we're going to have is Dr. Darshika Chhabra. Okay. She is a transplant nephrologist and medical director of kidney transplant program at Advocate Christ Hospital. She received a Bachelor of Medicine and Surgery from the University of Mumbai and an MPH in epidemiology from the University of Massachusetts. Her residencies and fellowships were completed at Northwestern and Michael Reese. She has been involved in many research projects and has numerous publications on the topic of nephrology. Thank you.
Thank you. Thank you very much. I will say Dr. Mikhail is a hard act to follow, so be patient with me. Hi, I'm so happy to be here. Thank you for everybody who set this up. If I'm going too fast or too slow, and if you have a quick question, I don't mind being interrupted. If it's something that's going to come up later on, then I'll save that answer for later in the presentation. So I have nothing to disclose. So, a little bit about what I'm going to talk about. So I'm going to talk about, what do we mean when somebody says is like, you're overweight, obesity, the health issues related to it, and specify a little bit more and focus a little bit more on kidney disease because, that is my specialty. So, as you can say, it's like, just the weight, like the number doesn't tell you much, right? It could be somebody who's tall, the same weight, and somebody who's shorter, but then, so it differs. So this is where, like we try to, like, define this a little better. Who really is overweight? And then, one of the measures is this body mass index. So the body mass index takes into account the person's weight in relation to their height. So now to give you an idea, so this graph kind of looks at, like a person's height compared to their weight. So depending on, where they fall in the zones, they could be underweight, which is also not healthy. The green zone would be the ideal, overweight, and then the obese. And then, this is a little dated, but I liked it because it was a good graphic representation, because over time, like we've kind of evolved into, it's like these different categories of weight and BMI. So this is where we're at. So, so less than 18.5 BMI. So those are patients we consider underweight who are also having weight issues. The perfect, or what we call like the normal or healthy weight, is between like the 18.5 to less than 25. So that's where ideally we would like to, have patients be. Overweight is, up to less than 30. And then once we're talking about a BMI greater than 30, that's where we kind of have like these different categories. So there's like class 1, where they're up to 35, then class 2, class 3. And I'll show you my next slide, which maybe is a little easier, in graphic representation. So we have like the class 3 and up to class 4. Like we used to refer to, patients as like morbidly obese, but then we're trying to get away from all of that terminology because there's a lot of negativity around it. We realize that, like it's a weight issue, that's a sensitive matter. It's important to make sure that whoever you're talking to about the weight is comfortable discussing it with you, and to work at, like focusing on helping them lose the weight without embarrassing them, really, to understand the importance of, having those discussions and to be sensitive about it. So I just wanted to show you that there are lots of calculators available online. If you're not too sure what your BMI is, most often at doctor's visits, they do tell you, they give you they ask you what your height is, they weigh you. And very often, in addition to, your blood pressures, your heart rate, one of the things that they do is the weight. So you can put in, your height and the weight, and then you can calculate it, and then it gives you, the number. And then very often, like especially the CDC website, I like that because it kind of gives you a little bit more detail. It kind of tells you where you fall in the category, and then there's a little follow-up, make sure that you're following up and talking to your physician and things like that. So, to give you an idea about, what is, the problem and what is the extent of it. So, of course, over the last, like, say, 20 to even 40 years, like it's been becoming more and more of an issue. To give you an idea, like currently, like about 1 in 4 persons is obese, and we're talking about the United States data. And they've changed, how they've kind of looked at it. So this is interesting because these maps kind of look at how many patients from the different states reported what their weights were. And it was like a survey. So if they didn't have like enough responses come by, like the white ones, if you see over here, like the white states, they didn't have enough data. So it's like the blue is good. And then as you get, like to the darker shades of red, like those are states that reported like higher weight. So like, like more obese patients. So this goes from like 1990. So you can see in 1990, that was all lighter blue. 2000, we started seeing more of the blues and the yellows. 2010, much more, of reds and darker reds. And then I'm going to show you a little bit more recent data. This is 2013. So once again, the greens, the yellows are those that have like less percentage of people who reported being overweight or obese. And then the darker red are the higher prevalence of obesity, the states. And this is the most recent one that they have based on this surveillance tool in 2024. So as you can see, like we really have a lot more oranges and reds and the deeper reds, which are, indicators that we're probably, evolving in the direction that we don't want to. So now people looked at, it's like, so who is at higher risk? So, they looked at age. So the middle age group, so adults, which they report between like the ages of 40 and 59. So they were 30% more likely to be overweight and obese compared to the younger age group. And these were talking about 18 to 39 years, and 25% more likely to be obese compared to the older population. So now in terms of race and ethnicity. So, just to summarize, like this list from Asian, white Asian, Hispanic adults, American Indians, Alaskan Natives, and the African Americans, this goes in ascending order. So the African Americans are at highest risk of, being obese. Then another thing which was interesting, which stood out is, education level. So they found that if you had a college degree, you were less likely to be overweight and obese compared to somebody who had no high school degree or a high school diploma. So, once again, limitations of the BMI, so height is one of the issues, but BMI sometimes doesn't give you a good indicator of, what the person's muscle mass is, which is, what we're striving for, to decrease, the fat mass and improve the muscle mass. So then we started looking at, maybe like waist circumference is a good indicator. And this, it's still, people do keep an eye on it, but then it also fell out of favor because now we have like these machines that can actually give you, it's like not just your weight, but they can give you what your percentage of fat is and things like that. But to give you an idea, so it's like, it's like the wider the person is, we worry about, like what the fat mass is. So it's like kind of like an indicator. Then they're like, oh, okay, it's like, but some people carry the weight differently, does it make a difference? And then, yes, it does, because you don't want to have like too much of what we call abdominal mass or visceral fat. And that also, is something that people spoke about, but then, over time, like it doesn't matter. The truth is like, the more fat that you lose, the better, your outcomes with a whole bunch of medical issues. To give you an idea about all the health issues that are related to obesity, you can pick anything, and yes, there will be a connection, to go from head to toe, strokes, eyes, visions get affected, sleep apnea, snoring, and that has a whole bunch of, effects that follow on the heart, on the lungs, heart disease, diabetes, high blood pressure, lung disease, liver disease, the pancreas, fertility, both men and women. It's associated with a whole number of cancers and increased risk. And of course, just because of like the sheer like weight, there's issues with arthritis, like more wear and tear on the joints, veins get, compressed, blood clots, and of course, like things like gout. So, already anything to everything can be affected. Focusing on kidneys a little bit. So, kidney disease, yes, we know like it's important, but how much of the population is affected with kidney disease? So 1 in every 10 patients is most likely to have chronic kidney disease. So you can imagine it's pretty high. And what's worrying is that very often people don't know that they have kidney disease. If you don't have that regular follow-up with physicians, you get your blood work checked, urine tests done, very often, it doesn't cause any problems until it's pretty advanced. So this looks at, how many patients are affected with a particular ailment that ultimately leads to causing kidney disease. Diabetes is the biggest one, and it's always been that way for years and years. Like it's anywhere from like 35 to 40% of people with diabetes who end up with kidney disease. High blood pressure comprises about 30% or so. Then we have things like glomerulonephritis. These are things that could be related to infections, sometimes things like lupus. There's a whole bunch of diseases that fall into this category. And then there are like a few others, cystic disease. If you've heard of people who have polycystic kidney disease, like those are some of those that comprise this category. So, what's the relation? So, so being overweight or obese, sometimes, it may or may not cause diabetes, but sometimes it makes the diabetes more difficult to control. The same thing with the high blood pressure. Diabetes and high blood pressure, even if people are not overweight, can cause kidney disease. And then just being overweight, even if your blood pressure is fine, even if you don't have any issues with diabetes, being overweight just because it's more of work. So actually like wears the kidney out sooner. So these kidneys and those filtering units, so they tend to overwork, and then over time they give out. So that itself can cause kidney disease. I liked this. So they referred to it kind of like a domino effect. The nice thing is that even though like there are a whole bunch of things which are listed over here, and I'll go through them in a little bit, like it doesn't follow a pattern. Like it gives you an idea about, yes, one thing can start and it sets off everything into motion. Or it could be that, it's like you start with something else, and then, it's like it kind of, all interrelates. And then unless you get everything kind of, like worked at and get it in check, over time, it just progresses and causes, problems. So beginning with, say, like say obesity, then we have, I'm not sure, and I'm sorry, it's a little small, but like, this second like little row says impaired insulin secretion, a lot of which we were talking about earlier, the insulin resistance that can lead to what we call pre-diabetes. So, you still have a little bit of ability to kind of control your sugars. Your body is not quite, at the point of diabetes, but if something is not corrected at that point, it could progress. So then you have diabetes, high blood pressure, dyslipidemias, high cholesterol or abnormal cholesterol, lots of strain on the kidney. Albuminuria is when protein starts to spill in the kidney, spill out of the kidney into the urine. So then over time, that can just perpetuate and cause more kidney damage over time. CKD is chronic kidney disease, liver disease, and depending on how all of this, plays with each other, it's always more of a risk if, all of these are not under control. So if cholesterol is not in check, diabetes and high blood pressure not in check, over time, they can cause issues with the blood vessels. Small blood vessels, big blood vessels. To give you an idea, some of the smaller blood vessels in the brain can get affected, causing strokes. It can cause issues with bigger blood vessels, causing circulation and blood flow problems. So you have like the strokes, the atherosclerotic heart disease, heart failure, amputation because of circulation issues, gangrene. Lots of the issues, especially when you're diabetic, people do have to follow up regularly to get their eyes examined, not just like a regular, to check your number and what the refraction is, but also to have the retina looked at, because that can cause issues with the blood vessels in the retina, causing retinopathy. Neuropathy is when the nerves get affected. And then, of course, all of this can cause kidney issues, vision loss. And then depending on how these progress, very often, just perpetuates. And then if you don't try and, block this domino effect over time, especially when it regards to the kidney, it can lead to, what we call end-stage kidney disease. I'm sorry, I know that was a lot, but, it's just to give you an idea about how, everything kind of plays off each other. So of course, say prevention. So what can we do really, to prevent, especially kidney disease? But the truth is it helps everything else. So, you got to be careful. Depending on your lifestyle, depending on, it's like work, how much you need, like, are you eating more calories than you can burn? Poor diet, the food choices, exercise, lifestyle. Unfortunately, there's some things that we cannot control, genetics, behaviors, is there something that can be changed to, improve on these unfortunate learned behaviors that have been going on for years? To be very mindful of, portion sizes. And then also negative emotions, it's always like, you have to look after everything, the physical health, the mental health, because they do play off each other. If you're depressed, it's like, and you do hear about it, the stress eating, like, you have to find another way to divert that so that you don't lead to, really perpetuating these behaviors. This was, also, of course, important, make sure that you can reach out to people for help. There are so many aids, as you heard about, that can help make things easy on you. It doesn't mean that it's a substitute for the hard work, but it definitely makes it easier. Weight loss, like with diet, exercise, and behavior modification. It's helpful to sometimes, keep a food diary. A lot of these programs like Weight Watchers and things like that, like they do, right? They ask you to like measure how much you're eating, like to put it all in that little app, if you like, or, to keep track so that you know how much, you're actually putting in your system. And then like little tricks, it's like, don't go shopping when you're hungry. You tend to, pick up things that are easy fixes and not always the best choices for you. Easier said than done because there are fast food places all over the place, like try and avoid passing in front of them. So, food choices matter, of course. It's like if you can, depending on, what's safe for you to eat, if you're a diabetic or hypertensive, if you have restrictions, can you pick something healthier instead of, like the fast food or the quick food? Like portions, right? We've really unfortunately grown accustomed to expect more, right? You want to get more, but maybe consider, eat half of it, save the rest for later. So you're still getting what you paid for, but at least you're not putting it all in your system. Because, this is really a comparison of, what we have grown to expect and what is an actual serving. And then, of course, like I laugh because the truth is like those big gulps are really big, but over time, this is really how they've evolved. Like 1955, so the original McDonald's was 7 ounces. And then in 2012, a kid size was 12 ounces. And then, of course, like it just goes crazy from there. And most often the truth is you're not filling this with water, right? You're filling it with like a very sugary drink that's probably not the best choice. So, this we've already spoken about, it's like make sure that you talk to your doctor, look into what the options are for you. And it's important to have like the right team guiding you. Dr. Mikhail's team is amazing because, they really have like that holistic approach. They look at, really every aspect of it. And it's not like, okay, you're coming here, you're going to get surgery. You have to, go through like the process and to be guided appropriately. That was all that I had, but I do want to put in a plug. This month is Donate Life month. So it's like the month to like really raise awareness for all the donors, living and deceased donors and their families, and to really is like be thankful, for the sacrifice that they have made. I'm also over at Christ Hospital. This is my phone number. I do have a few cards over there. And I find this funny because, of course, you cannot miss this building, right? But I'm not in the big building. I'm in this little building over here. That's like when the same building. So I love this, but I'm like, it's like we're in the corner, but we're there. Okay. The National Kidney Foundation is a good resource that's very reliable. If you have more questions about, like kidney disease, and we have an Illinois chapter, like they do lots of programs, really it's like over the year, they have lots of forums, discussions. And if it's something, that you or somebody is interested in, I would definitely say this is a very reliable resource. And then the Gift of Hope is the network that kind of, facilitates organ donation and transplantation in our area and a few of the surrounding states. I am open for questions. Thank you very much, Aurora. Very good audience.
Any questions?
I have a question.
Sure.
Dr. Mikhail.
Yes.
When you showed the abdomen and it had the different centimeters for the punctures,
Yes.
when you do gastric bypass, are they sticking you in 4 holes? Or
It's the same for all of the surgeries. It's the same. They're all the same 4 holes. Mm-hmm.
I have a question for Dr. Mikhail.
Yeah.
Regarding the procedures like for instance gastric bypass.
Yeah.
How does not having a gallbladder affect that? Because the gallbladder make the bowels.
Yeah. So no, the liver makes the bile, and then the gallbladder stores it. And then for the sleeve, it doesn't matter. So we do check we check a liver ultrasound. We want to see what the size of the liver is. We want to see if there's any signs of cirrhosis, which is a little bit further down in that the domino effect. I love that slide, by the way. It's so good. So, so they can have cirrhosis. So we do an ultrasound. If there's stones in the gallbladder, only with the bypass and then the SADE do we remove the gallbladder, because that's the one organ that's a little bit difficult to deal with. We know with weight loss, you have a tendency, whether it be with medications or surgery, when you lose weight, you have a tendency to form stones in your gallbladder. And so only 20% of the people that have stones are symptomatic, and those are the ones you're supposed to take out. Having said that, if we're in there, we're doing a weight loss surgery, and they already have stones in their gallbladder with the bypass and the SADE, that's the one organ that's difficult to deal with, so we will take the gallbladder out at the same time. Yeah. But it doesn't affect anything in terms of just removing the gallbladder. It actually probably makes our work a little bit easier, because it's one organ that we don't have to deal with. Those bypass and the SADEs are a little bit difficult to deal with that gallbladder if it's still in. So that's the only thing.
Did you say a median age for when people get those bypasses?
Yeah.
Like what's the age, the average?
I don't know current data. I would say that like I could give you like probably 10 years ago, it's probably like 45, 50. But we've done it on folks that, I know you're gonna think I'm like, what does it matter with this guy's practice? But we've done it on like 80-year-olds, right? So if they're overweight and they have like a large hernia or something like that, and they're functional, they're doing all the things, they're going out to, I know it sounds crazy, but we've done a bypass on an 80-year-old, because 80, because she had her stomach up in her chest, she was of size, you can't just fix the hernia, it's gonna recur, even at 80. And so, yeah, but yeah, there is no age limit, it's more about functionality and than age. But median age, I would say primarily women, and then around 45.
Was thinking on the opposite end.
Okay, so young,
It seems like this generation,
yeah,
they're like obese. I mean, they've grown up on the super size and that's all.
Yeah.
What's the youngest?
so we have a kids program. Unfortunately, it's just at Lutheran General. And that's a really hard I'm not involved with it. I mean, our practice is, but I'm not involved with it. It's very difficult. So we will not operate on anybody until they're 19 or over. But we will work with them at a younger age. But of course, the parents have to be involved as well. Remember, there's a genetic component to these things as well. So, and some of it might be even environmental. Nobody knows. We're still trying to figure it all out, right? So, but kids that are obese before the age of 6, 7, 8, it doesn't make sense. And usually there's a genetic component to it. So if we do get a history of that, it doesn't change anything, but there's a free genetic test that we can offer them. And then they can at least have an answer of like, well, I don't understand this. So just try to be more aware, like when you see somebody who's obese that is young, it's not the mom's fault. It's not, like just be careful, because there is a real genetic component to these diseases, and we don't have the treatment. All we have is GLP-1. There's some leptin for like really young folks that are born with leptin deficiency, but that's pretty rare. But a lot of them we can identify it, but we don't have a treatment for it yet.
So if you've been living without a gallbladder for years, is there any problem with doing those surgeries?
No.
Yes.
Are they reversible?
Yeah, so the sleeve is not reversible, but we can convert it to like a bypass or a SADie. But the bypass we can reverse, and then the SADie we can reverse, but it's not very practical. It's not something that's done commonly. I've been in practice for, I don't know, 17 years, 18 years, and we've done it 0 times. And as far as referral out, I did it in fellowship once, but I haven't even had to refer somebody out. We've had questions like, okay, go and reverse this patient. And so the patients come to us, and you find that, they're not doing the things that they're supposed to be doing. So if we can get things straight, then it's usually fine.
Okay, on the one surgery where they do the stitching from within, and you were saying like.
Yeah, the endoscopic sleeve gastro. Yeah, so that one is actually covered by insurance. So it does have a CPT code, which is a code that we can use at the hospital. So the hospital they want to get paid, right? So they can build big buildings like that. So but yeah, so there is a code for it. And so I'm surprised like how many insurances actually are covering it. Having said that, it's a newer procedure. There's 2 folks that have done a lot of them. One at Rush, one in North Shore, and then I don't know very many other docs. I mean, I'm certified in it, but in terms of like doing it, I have a few patients that are interested in it, and I've told the one that's like ready, I'm like, you would be my first. He's like, I'm excited, let's go. And so it's like, okay. So, but yeah, there's not a lot being done. But we'll see, real world versus like studies, like how much weight are you going to lose? We'll see. What it comes down to, but it's a different patient population too. A lot of the folks that do the surgeries, or so there's some folks that are like, well, I don't want to take any medicines, or the medicines aren't covered. And then there's folks that are like, I'm not going to do surgery either. That's too much. So it's like a different patient population than we've seen in the past. And so those are the ones that are interested in this endoscopic sleeve. So at least it's a treatment for something. Maybe if they do that, they maybe might be more open to medicine. But it's definitely an option to help folks get weight off, because like as we saw, any amount of weight you lose is going to help you. So 10% weight loss, it already affects your kidneys, it affects your blood pressure, affects your cholesterol. So any amount from your heaviest is great.
You mentioned, Doctor, the classes of obesity.
Yes.
So would that be a factor of approval
Yeah,
They have to be in a certain class or have a certain weight.
yes. So for insurance purposes, you have to have a BMI of 35 or higher, which I think is class 2 or higher. With plus minus if you have to have a medical issue. So it has to be diabetes or high cholesterol or hypertension, kidney disease. So if you have one of those, then insurance almost ultimately covers it. Usually they say a BMI over 40, which is class 3 obesity, is covered regardless of whether you have a medical issue or not. And then medications, it's usually 27 or higher. But medications, some folks, if they cover obesity, it's 27 or higher. And then if the patient has diabetes, then we can always just put them on the medication. Yes.
My issue, the test says abnormal kidneys, but the doctor said the test is wrong. I don't know what to do with that.
I could take that.
Right, and also because I had cancer,
Oh,
they didn't tell me that they had steroids in
yes.
the medication.
Mhm.
And it was because somebody told me, and they said, just ask them, and they say sometimes that could, because they rapidly dropped 80 pounds.
Mhm.
Now I'm slowly gaining all that weight back
Mhm.
because now I'm in remission.
Mm.
So
Congratulations.
it's like, yeah, I was diabetic, I was pre-diabetic cancer,
Mhm.
cancer's in remission. Now my numbers are going back up, and they saying, oh, it's just the steroids, but they can't tell me when I can get what I'm gonna do about all of this. It's a lot.
I'm sure it's a lot. The truth is, like with kidney disease, so just as we're aging, even if there's like no extra, insult, like high blood pressure, diabetes, cancer, whatever it may be, medications, like as we're growing older, we lose a little bit of kidney function. So that is kind of like part of the normal progression. So yes, over time, even if you're healthy otherwise, you do develop kidney disease, but that's normal and expected. The concern is if, it doesn't follow that trajectory, which is, that slow kidney loss over time, but then you suddenly have a jump up. So then the question is like, what's causing it? Could it be medications? And that's why, we don't like the medications that can be very hard on the kidney, like ibuprofen, Motrin, Aleve, the naproxen, all of these that we call the NSAIDs, like because they're so easily available over the counter. The prednisone itself shouldn't cause any issues with the kidney disease, but it may be something else that's going on. Sometimes these big fluctuations in weight, depending on, if you're hydrated well enough, if you're having diarrhea, if you're sick, sometimes, like the kidney function can take a little bit of a hit. Then, the number, like the creatinine that's being watched, that can go up. But then very often it can be just acute. So if you recover, then the hope is that it gets better. So I'm not sure if, you're kind of in that phase where they're not too sure in which direction, you're going to, end up. But the truth is that close follow-up is key, making sure that somebody's watching, not just the kidney numbers, but also, everything else, like how you're doing. A good place is always your primary care physician because they see, the whole approach. They see what every other doctor might only be focusing on their specialty. For example, like the cancer doctor might be only looking at the cancer. Exactly. And then if you have, like something that you're worried about, even though the primary care is watching it, you could always request, please see a specialist, so ask to see, a nephrologist so that you have another set of eyes looking at things. They may be, they may be aware of like newer tests that are out there that, that you can watch and not just, like the basic set of labs that may be a primary care. So it's always good, I think, to have, like a specialist involved. They may say, there's nothing more to do. Your primary care can watch you. Come and see me in a year, which is also all right. But at least then you have that reassurance that, that you've done everything you can in the moment. But the truth is like, some can be just like an acute episode when the kidney function, takes a hit, but then it resolves. And then the only thing that you need to do is check it again. But in the meantime, I think there's somebody who has to reassure you that there's nothing else that you need to do now in the moment.
That's why I don't have the reassurance of
And I
primary
think,
care.
and I think that's what you got to find.
Yeah,
So, maybe, I would say like maybe see, like another specialist. Sometimes, it may be the right specialist, but you just need another opinion, which is completely okay. Like we all do that. So you can hear it from somebody else that, they're doing everything right. There's nothing else I would do. Because the truth is sometimes in spite of doing everything that you possibly can, things happen, right? Things progress. But I would say that as long as you're doing what you think is right in the moment with the help and guidance of your docs, and reliable sources, because the internet has way too much out there. They tell you to do this and that. And like, oh, it's like these supplements and they charge you so much. They have like these infusion clinics, and like, I think all of that is like gimmicks unless you're, getting that reassurance from a doctor that, that this is something that, that really could benefit you. I would say, don't do anything that might actually harm you.
Are there any kidney problems related with all these autoimmunes people are getting, the MS and their
A lot.
rheumatoid?
Yes, a lot.
Thyroid and.
Absolutely, yes. And that's a big, like, it's not as much as, I think that the effect that diabetes and high blood pressure has on kidney disease, but yes, it is. It could be anywhere from, I would say, 14 to 15% of people with kidney disease who have things related to autoimmune disease.
Yeah.
So that's why I always tell patients, especially if they have something like, like the MS, the lupus, make sure that they're not just following up with a rheumatologist, but depending on, what else gets affected, to also, have that other specialist. For example, it's like sometimes, like lupus can affect anything to everything, but not everybody gets affected by kidney disease. Sometimes there are patients who have lupus, but the kidneys are fine, but then the heart's affected, or, like the brain's affected, so depending on, what gets involved, to make sure that, that they're guiding you appropriately, that, yes, it's like I am overseeing your lupus care as a rheumatologist, but I need you to see, like a specialist to help guide us if there's anything else, besides the lupus that's going on. But yes, it's hard because it's not like a single person, you need like that whole village.
Why is there so much of an increase in autoimmunes? I mean, years ago, we didn't have these things.
I think a lot of it is being more aware. And then, I think the autoimmune diseases too have evolved quite a bit. Like, they used to have like, just like say lupus, and now they have like, so many more different categories, and then like the subcategories, like even with MS, it's like, I think we've learned more about the diseases. Like we've been diagnosing them, I think probably like earlier, but very often these autoimmune diseases, even today, it's like they get diagnosed so late because they present in so many different ways. Somebody might present with like seizures or heart issues, and then it takes some time for, like everybody to put it together, or they have like a rash, then they end up going to the dermatologist. Then they end up going to a rheumatologist because there are joints that are aching and paining, the nephrologist for like the kidney stuff. And then very often, like that takes a while, unfortunately, before it gets diagnosed and somebody, puts it all together. But I think we've definitely become more aware of the
Like the
autoimmune
rheumatoid
diseases.
arthritis, I mean, my grandma had.
That's right, that's been along for a long time.
Just arthritis.
They called it an autoimmune.
That's true, and then we have
Thyroid, nobody called that an autoimmune.
That's true, and then the thyroid also has like different buckets and that can be put into, but I think the nice thing is that we also have more agents available to us these days, such that we can treat or at least, like help with symptoms now that weren't there, maybe 30 or 40 years ago. It's still very expensive, but hopefully, like very, very often, like many of these insurances do cover them now, which does definitely help. It's true. Thank you.
Thank you.
Thank you. Thank you very much.
Yes. Before you leave, and does anybody, I have future programs, if anybody wants to, just raise your hand.